So should I move this clip? And I have to say, when I got this topic, I said to myself, I'm really surprised that I haven't seen this topic more commonly, because this is something that we see all the time, that the MR is down a little bit, the gradient's now in the 4 to 5 range, what do we do next? And we've done some interesting things in our lab, but then I also thought about this case, which would be an interesting one, especially for Paul and the rest to see. So this is an 87-year-old male with NYHA3 heart failure symptoms due to severe mitral regurgitation, aortic valve regurgitation, and atrial fibrillation. In October 2015, he had aortic valve replacement with a 25 millimeter Magna Ease valve, mitral valve repair with a 36 millimeter Edwards Physio 2 annuloplasty ring, and closure of the anterolateral commissure, and Cox-Maze 4 procedure, LAA ligation, and repair of ascending aorta with felt wrap. I think if you could really close up a package with a way to not go back in again, this would be one of the ways to do it. Subsequent anterolateral commissure failure followed by severe symptomatic mitral regurgitation, and referred for percutaneous mitral valve repair. So as you can see here, this is something that I thought was really interesting to follow the case before, because of what we see here, which is this laterally directed mitral regurgitation. And it actually is a pretty severe wraparound jet, and I had to really capture just this frame to really just show how much it goes around, because it's really hard to capture it on video. There's a very small posterior leaflet, and you can see here how much we had to grasp in terms of the posterior leaflet. So we started thinking, because I had just seen the publication that was presented about the previous case, and we were starting to think about those types of issues to try to see whether that's something we'd want to consider. But we would like to try to grasp a leaflet if possible. So here's just showing some 3D, because we're talking about different resolutions and different things about where exactly the jet is coming from and what does this look like in terms of the other 3D anatomy. So the first thing that we did is that we went for this in lateral placement. So we went all the way out to the lateral side, found that we had mild leak, and then a 6 millimeter gradient. So then the next step that, the rep and the echocardiographer and us all get together and say, is this the correct place for the clip? Do we want to move it or do we not? And this is what it looked like in terms of fluoroscopy. And this was our result. So should I move this clip? And this is kind of roughly where we were going. The breakdown, the good, we have both leaflets, we have a decrease in MR, we have a very acceptable gradient. As far as the mitral valve area, there was really no difference in the mitral valve area, which makes sense because we were all the way buried in the commissure. The bad was that it was very tough for us to evaluate grasp quality. We could not tell how much of the leaflet was inside. We could not tell whether this was something that, even when we replayed, the imaging was just so poor for us to be able to say that this is something that we actually had all in hand. And the reality of it, for many of us, is that if it's a very tough grasp and you don't think that you're going to do a better job, after many painful experiences of having moved it and not getting a better result, sometimes we just leave the first one be. So after we left the first one be, sometimes you move and sometimes the world moves for you. Because what happened right after that was a single leaflet device attachment, right? So you have a single leaflet device attachment seen on echo and fluoroscopy, and now it's very easy for the echocardiographer to find the MR. They just look for the clip and the MR is right there. The gradient is now 3 millimeters of mercury. So now we were trying to think about what options to do, and this was one of my partner's cases. He called for, he said, do you mind just coming in and trying to figure out what to do? And I said, we already have a clip there. This is, it's going to be very hard to do anything, is it? But, and then the surgeon was in the room. Eric Lair, he's our surgeon. He also is in our mitral clip program. He said, I have very little interest in reoperating again. It's going to be very high risk. If we are going to reoperate, it's going to be a replacement. So I said, does that mean whatever we do here, you're okay with? He said, yeah, sounds good. So I said, all right, that opens up a few options. So the second clip, we went in and we did a very different technique. I think the technique that you can see here is we're coming from a very different angle. We're basically have straddled all the way on the right atrium as opposed to the left atrium, and we're coming in much more diagonal compared to the first one, which was much more perpendicular. That was the old approach and the new approach. So now we have a grasp that we've done here, and in retrospect, and in perspective, we were thinking to ourselves, we don't really know whether we've grabbed leaflet or not. We probably have just grasped a bunch of Chordae. And we have a very lateral insertion of our clip at about 45-degree angle away from the actual leaflets. So then after this point, I said, well, it's going to be very hard to figure out how to stabilize this thing. So we should try to think about that aspect of it, because we've already had one SLDA. The worst thing would be to have two. So at that point, then we did purposeful rotation of the cords, just basically spinning this clip in place, one side all the way to the other, and just going back and forth, back and forth, back and forth between these two pictures. Kind of almost like how spaghetti, you take a fork and just turn it around inside spaghetti. We did it about 5, 6, 7 times. So purposeful rotation of the delivery sheath and clip, and a decrease in mitral regurgitation with rotation. So you can see here, this is what it was like, and then after some rotation, it actually seems to me, to my very non-trained eyes, compared to the echocardiographers in the room, a little bit better. But we can convince ourselves. We have objective evidence.
You're hired.
So the next thing we were saying is that now we have to stabilize this thing, because I said, we're going to let it go. It's just going to whip back the other way. Then we haven't done any good. The gradient was still only 3. So now we said we need to purposely retain this gripper line. So as I pulled everything out, it left the gripper line in place. And as we tugged the gripper line, with the sheath still there, the MR stayed. When you let it go, the MR got worse. So he said, well, we got to, somehow this should be tightening in place. We took a page from the TMVR Abbott Tendyne model that a tether would be a good idea. So at that point, we removed the clip delivery system with the gripper line intact, and then we stabilized with a septal occluder on the ASD that we had created. And then we cut the gripper line at the femoral vein surface below the skin. So this is how it looks. There's the first clip, there's the chordal clip, and then you have the septal device all the way in the back. So to kind of discuss this, recurrent regurgitation after ring implantation can make mitral clip very difficult. Clipping directly to the ring by Paul has been reported, but for us was very challenging because we were very close to the commissure. It was very just tough to grasp anything in that regard from the ring standpoint. Direct chordal clipping rotation may be an option to bring the leaflets together from below. We don't always have to grasp the leaflets, we just have to grasp something in that region, and then whatever's on top of that, whatever we grasp, should come together. And stabilization tethering can occur on the atrial septum with a retained gripper line if you're worried about a clip moving. I think that's something that I learned from this case because it seems to be holding pretty well at about a year. And conclusion, this spaghetti technique can be an option, truly prohibitive risk patient population for such patients where leaflet length is too short for direct grasping. Thank you very much.
All right, so Samir, you win the I Got Guts award for this afternoon because intentionally wrapping a clip in the cords, spaghetting is, boy, that takes a lot of guts.
Well, I think the biggest thing, the surgeon saying that he would go ahead and replace, and I said, all right, so we have full carte blanche to whatever we want.
All right, before we get to Mike's anatomy lesson, Danny, go ahead.
Samir, just a quick question.
Yeah.
You know that valving ring results are a bit inferior, but this is a physio ring. It's one of the favorable rings for valving ring. Did you consider?
Absolutely, and that was something that could have been done. I think if we had the mitral clip had not worked, the surgeon and us would have then aborted and then said we now have to decide which way to go in terms of either a valve in that option or also the repeat surgery. The one concern that we did have was the fact that we already had a single leaflet device attachment. So that's when I entered the equation of this whole process. And at that point I was saying, well, we already have one leaflet that's attached. Either we are going to eventually put a valve in, but I didn't know how that clip would then interact with that valve. What if every time during ventricular contraction it gets sucked up inside the valve? That was one of the things I was worried about.
So Danny, question for you. Lampooning this or a basilica to remove a clip that's SLDA?
But then, well, where will it go?
I thought you said I was brave. That's really brave.
Put it in a snare and then do the slicing. It's doable.
Yeah, and pull it out the aorta?
Yes, I think that it's doable.
Yeah.
Never did it before. I imagine that it could be.
Danny,
Well,
we'll make a bunch of patients for you, and we'll send them right over up the street.
So there was a question in back.
I was just curious about anticoagulation therapy afterwards with this string that's kind of pain attached to the septum.
Yeah, the patient, despite having the maze, was still on Coumadin, so we just kept the patient on Coumadin.
And did you tie the gripper line to the ASD device? Or how
No,
did you
so
just thread
it was. I was thinking about threading it through, but then my worry was that it would actually rotate as it was coming through the sheath. So it just pulled it and then just released the left atrial disc and then released the right atrial disc and just said wherever it's stuck, it's just going to pin.
You've already rotated up all your ports. Why not rotate
So Mike, she's 87.
I'm a little worried. I'm glad it worked out. I'm worried about rotate. I'm worried that would cause an abnormal stress and they would break
Absolutely.
the first 6 months. I'm glad they have it. I mean, who knows? I've never
Right.
done this, so who knows? I think that I probably would have, if it wasn't an easy thing to do, told Colin Barker, my guy that does with Colin, let's just stop, move to the transeptal valve and valve. This is a very favorable ring to do this in. It's not a hard thing to do. He hasn't had a previous transeptal procedure, so it's not. He's probably got a big atrium because he's had AFib before. He had a maze done. He's probably got plenty of working for him.
Myra?
The gradient, I thought I heard the first time when
Was
the
six.
was 6.
Yeah.
So I think that was a moment to move it or not. I think that was a moment to
To,
discuss.
yeah,
It's
to take
already
off,
6.
right.
We don't, with the clip, it's unpredictable how good the result is going to be at the end. So you never want it to be an after 2, and 6 is already under anesthesia. So who knows what
Exactly,
6 will
8
be
or
when
9.
The patient is walking. I don't know how active would this patient be, but at a grade of 6 with the first attempt, with a good. This is different than the prior one. The prior was a band with, like Danny said, this is
Yeah.
a good one
This
to
is a good
go
one,
about.
yeah.
Maybe that would have been the moment to maybe move it, get it
Absolutely.
out. You already have the access and the negotiation to that.
No, I think this was actually early part of 2016. So I think this was a little bit earlier in kind of the overall experience of mitral valve inside ring and so on and so forth. So there were
Still
definitely,
off-label.
yeah, very much more off-label, and this was on the on-label side. But and definitely in 2017, that should and probably is more of a first option than this.
I think that's one of the problems we all have when we watch these cases. We think what we do today.
Right.
I mean, forget this was what somebody was doing a year and a half ago, and we all change over time.
Yeah. But that's why we share these cases.
That's what you
Right?
basically
Yeah.
do.
Great case.
Thank you very much.
Samir, thank you very much.